Dealing with complex health conditions, well, it can feel pretty overwhelming, can it? Especially those chronic ones, the ones affecting something as basic as just moving around.
Absolutely. And when the body's own immune system kind of turns on itself, attacking healthy joints, it just adds this whole other layer of difficulty.
Yeah, it's tough stuff. Okay, let's dive into this. For this deep dive, we're really focusing on one specific condition, immune-mediated polyarthritis.
Right.
And we're looking specifically at how it's treated and managed, drawing directly from a pretty detailed medical text you shared.
Exactly. So the plan is to unpack what this source tells us, what the condition looks like according to this text, what the treatment options
Some
are.
challenges,
Yeah,
what people should realistically expect,
sure.
all based on the source material.
Precisely.
So how does this text actually describe the condition? What's the picture it paints?
Well, it talks about it affecting multiple joints, obviously polyarthritis, and causing quite significant damage.
Like what kind of damage?
With things like cartilage destruction, these specific bony growths the text calls enthesiophytes.
Okay.
And really noticeable changes in the joint lining, the synovial membrane. You see thickening, inflammation, hypertrophy. It's quite dramatic.
And I think you mentioned the fluid inside the joint changes too.
Yes, exactly. The synovial fluid often becomes cloudy, and there's just more of it, increased volume.
So right away, this source shows us it's not just, a simple ache. It's a deep inflammatory process changing the joint structure itself.
That's a good way to put it. It's systemic and structural.
Okay, so faced with that picture, multiple joints inflamed, damage happening. What's the general approach to management according to this text?
Well, interestingly, the source suggests it's often managed on an outpatient basis, depending on how severe things are, of course.
Right, not always a straight-to-hospital situation.
Right, necessarily.
And what about the non-medical side of things? What does the source say helps, besides drugs?
Activity limitation is key. That comes up strongly. Basically, minimize anything that makes the signs worse.
Makes sense. Don't push through the pain.
Right, and diet for weight reduction is also highly recommended. Less weight equals less stress on those already struggling joints. Pretty straightforward, but important.
Yeah, basic physics almost. What about more like hands-on care, therapy, support?
The source does mention nursing care considerations. Physical therapy has highlighted things like range of motion exercises.
Mental movement.
Exactly, and even swimming, which is great because it's low impact. This might be especially useful if mobility is really compromised.
Okay.
And in those more severe cases, the text mentions bandages or splints might even be needed for support.
Now, when you talk about serious joint problems, a lot of people jump to thinking about surgery.
Mm.
But this source, it seems to have a different take.
It does, yeah. It's quite clear, actually. Surgery is generally not seen as a good primary treatment for the immune-mediated condition itself.
Why not?
Because it doesn't fix the underlying problem, which is the immune system attacking multiple joints systemically. You can't just operate on every joint.
Right, okay. So not the main fix. But are there times when surgery is part of the picture, according to the text?
Oh, definitely. And this is really crucial. If the immune reaction is actually being triggered by something else, like an infection somewhere else.
Like a hidden infection fueling the fire.
Exactly. The source uses the example of a pyometer, an infected uterus. If that's the case, removing that source surgically is critical.
Right.
And sometimes the source says that surgery to remove the trigger is literally the only treatment needed for the joint problems to resolve.
Wow. So treating the cause, not the symptom directly, that's huge.
It really is.
What about operating directly on the affected joints, though? Not for a trigger, but for the joint itself.
The source mentions that joint replacement surgery, arthroplasty, like a total hip replacement, or maybe removing the femoral head, an FHO,
Right.
that might be considered. But usually only if the hip is like the single biggest problem joint causing most of the issues.
So very specific circumstances. Not for the general disease across many joints.
Precisely. And then there's something called arthrocentesis joint fusion.
Fusing the joint solid.
Yeah. The source presents this more as a salvage procedure, when pain and instability are just unmanageable otherwise.
The last resort kind of thing.
Pretty much. And it notes the best results for fusion tend to be in the carpus, the wrist area.
Okay.
For other joints, shoulder, elbow, stifle, which is the knee, or the hock, the ankle, the outcomes are apparently less predictable.
So bottom line from this source, if the main issue is the immune attack across multiple joints, surgery is mostly out, unless you're removing a trigger or doing a very specific salvage job.
That sums it up well, and that's really why the text puts such a heavy emphasis on medication as the core strategy.
Right, okay. So let's get into the drugs.
Mhm.
This is where it sounds like the source gets quite detailed. The first step.
The first step, if you can possibly identify it, is to eliminate any underlying cause. Like we said, maybe a chronic infection or sometimes even a drug reaction, perhaps to an antibiotic, could be the trigger.
Address the trigger first.
Yeah.
Always.
Always, if possible. But if you can't find a trigger or you can't get rid of it, then the source describes this typical progression for drug therapy.
Oh.
You start with a trial of glucocorticoids, steroids, powerful anti-inflammatories that also suppress the immune system.
And the source is specific, right? Using prednisone as the example.
Yes, prednisone.
Yeah.
It talks about an initial, pretty aggressive dose, something like 1.5 to 2 milligrams per kilogram of body weight, given orally every 12 hours for about 10 days to 2 weeks.
Wow, that's quite a dose.
It's an initial blast to try and knock down that inflammation.
And how do you know if it's working? What does the source say to look for?
Well, obviously you look for a clinical improvement, less stiffness, less pain, better mobility. But crucially, the source emphasizes rechecking the synovial fluid.
Ah, back to the joint fluid.
Exactly. The goal is to see that cell count drop way down the text. The text specifies under 4,000 cells per milliliter and see a shift towards mononuclear cells being the main type in there.
So objective proof in the fluid that the inflammation is calming down and changing its character. Makes sense.
Right.
And if you do see that positive response, what then?
Then the source advises a slow, careful taper. You gradually reduce the dose, usually every 3 or 4 weeks.
Slowly does it.
Very slowly. The aim is to get down to a maintenance dose, maybe something like 1 milligram per kilogram, but given orally only every 48 hours.
Alternate days. Why is that important, according to the text?
That alternate day dosing is a really common strategy you see recommended for long-term steroid use. The idea is to try and minimize the pretty significant side effects you can get with chronic daily steroid.
Yeah. Cushing's and stuff?
Exactly. While hopefully still keeping the inflammation suppressed enough, it's a balancing act.
Okay, so you get down to that alternate day dose. If the patient's doing well, no clinical signs for a couple of months.
The source suggests you might actually be able to stop the steroid completely.
Oh, that's the ideal goal then.
That's the ideal, however, and this is where it often gets tricky. If the signs don't resolve, or they persist, or if that joint fluid analysis stays abnormal despite that initial steroid push,
Then you need more firepower.
that's when the source says you typically add in cytotoxic agents.
Okay, the next level of immune suppression.
Right. And the text explains this combination. The steroid plus the cytotoxic drug is used for a synergistic effect. They work together to suppress the immune system more strongly than either one could alone.
Gotcha. What cytotoxic drugs does the source mention?
It details a few. One is cyclophosphamide. The dosing is weight-based, and it actually varies quite a bit depending on the patient's size.
Okay.
What's interesting is the schedule described. It's usually given orally every day, but only for 4 consecutive days each week.
Like 4 days on, 3 days off.
Exactly, a pulse therapy. And that's usually given while still on the prednisone, sometimes maybe at a slightly reduced steroid dose.
Okay, what else?
Another option mentioned is azathioprine, or a related drug, 6-mercaptopurine.
How is that used?
The source suggests starting at 2 mg/kg orally every day for maybe 2 or 3 weeks, then switching to every 48 hours for maintenance.
So also alternate days eventually.
Yes, and like cyclophosphamide, it's given concurrently with the prednisone. But the text specifically points out that these are often given on the days alternating with the steroid.
Ah, so prednisone one day, the azathioprine the next.
That seems to be the approach described, again, likely trying to manage the overall drug load and potential side effects. It gets complex.
Definitely sounds like it. The source also mentions leflunomide.
It does. It notes leflunomide can also be used synergistically, with the other drugs like azathioprine, prednisone, cyclophosphamide.
Okay.
For dogs, it gives an initial dose, 4 millikilograms daily. But a really critical point the source makes about leflunomide is the need to actually measure drug levels in the blood.
Oh, really? Like therapeutic drug monitoring?
Exactly. You adjust the dose based on plasma trough levels, aiming for a specific target. The text says 20 micrograms per milliliter.
Yeah, that requires quite specific monitoring. More involved.
It does suggest that. Then there's also oral thiomolate, which is sometimes called chrysotherapy or gold therapy.
Gold?
Okay.
How's that used?
The source mentions it as another option, given as an injection intramuscularly, once a week at 1 milligicaldrain, and it notes there are reports of it successfully easing symptoms in some cases.
Interesting. So several cytotoxic options. Once you start them, how long do you typically stay on them according to this source?
The typical advice seems to be continuing them for about 1 to 3 months after remission is achieved and seems stable.
Okay, so confirm remission, then continue for a bit longer.
Right. To solidify it, presumably?
And then for just maintaining that remission long term.
Well, the source suggests that alternate day steroid therapy alone is often successful if you can get down to that.
It's possible.
But the text is realistic. It acknowledges that if the clinical signs come back, or if that synovial fluid analysis shows active inflammation, again, it specifically mentions neutrophilia, lots of neutrophils, then unfortunately, long-term cytotoxic drug therapy might just be necessary to keep things under control.
So remission might require ongoing cytotoxic drugs for some patients.
It seems so, based on the source.
And what if the signs come back after you've stopped the steroids altogether?
Then you likely have to restart the process, potentially including cytotoxic drugs again. It highlights the chronicity.
Right. And how long does the source say it generally takes to even achieve that complete remission in the first place? It's not overnight, I assume.
Definitely not. The text gives a range, usually somewhere between 2 and 16 weeks.
2 to 16 weeks, that's a pretty wide window.
It is. It suggests response times can really vary quite a bit from patient to patient.
Yeah. Now, this source also talks about specific types of polyarthritis having different challenges, right?
Hmm.
Like in cats, feline chronic progressive polyarthritis, FCPP.
Yes, it does. For FCPP, the source notes that treatment might slow down the progression, but a complete cure isn't really the expectation.
So managing it, not curing it.
Pretty much. It often involves similar drugs, prednisone, cyclophosphamide, using those kinds of dosing strategies we talked about. But the goal is different, more about control and slowing things down.
And then there's another specific one mentioned. Erosive polyarthritis of the greyhound, EPG. The source sounds quite different about that one.
It really does. The description for treating EPG is, well, the source flat out calls it unrewarding.
Unrewarding, wow.
Yeah, it actually lists a whole bunch of drugs that typically fail to get remission in this specific form.
Like what?
Antibiotics, NSAIDs, even the standard glucocorticoids and cytotoxic drugs we just discussed, and also polysulfated glycosaminoglycan like Adequan.
So basically, the standard toolkit doesn't work well for EPG.
That's the strong implication from this source. It's a really key insight.
Yeah.
Not all immune polyarthritis is the same, and some forms are just incredibly tough to treat effectively.
That variability is critical. And it leads us right into some really important warnings and precautions the source includes. Things that could make treatment risky.
Absolutely vital information here. First, the contraindications when you absolutely should not use these drugs.
Okay, what are the big ones?
The source warns strongly against using cytotoxic drugs if the patient has a chronic infection going on or if they already have bone marrow suppression.
Makes sense. You don't want to suppress the immune system more if there's an infection or wipe out bone marrow.
Exactly. And it specifically calls this out as a risk in cats with FCPP, suggesting that combination might be particularly problematic.
Good to know. What else is a definite no-go?
A huge one. Glucocorticoids should not be used at the same time as NSAIDs.
Like aspirin, carprofen, those kinds of drugs.
Yes. The source is very firm on this. That combination significantly increases the risk of serious stomach ulcers. A very dangerous mix.
Okay, that's a critical clinical point from the source. Any others?
For the gold therapy, chrysotherapy. The source says it's contraindicated if the patient has kidney disease because the drug itself can be toxic to the kidneys.
Right, avoid if the kidneys are already compromised.
Precisely.
So those are the absolute contraindications. What about general precautions or common side effects the source warns about with a long-term use?
Well, with long-term steroids, the source highlights the risk of causing iatrogenic Cushing's disease. Essentially, the medication makes the body act like it's overproducing stress hormones.
Yeah, we mentioned that earlier. It's a known issue.
It is. And for the cytotoxic drugs, the source is very explicit. Bone marrow suppression is a frequent side effect.
Frequent, okay.
Which is exactly why the text hammers home the need for weekly CBCs, complete blood counts when using these drugs. You have to monitor those cell counts closely.
Wow, weekly blood work really underscores how serious that risk is.
It absolutely does. And one more specific warning for leflunomide. The source mentions that overdosing can potentially cause intestinal necrosis.
Tissue death in the intestines. That sounds really bad.
Extremely serious, yes. Highlights the need for careful dosing and maybe that drug level monitoring we talked about.
Given all these potential issues and the combinations used, does the source mention any known negative interactions between the different immune-suppressing drugs themselves, like prednisone interfering with cyclophosphamide?
That's an interesting point. Actually, the source states that within the recommended protocols for treating IMP, there are no known possible drug interactions listed between those specific drugs.
Ah,
The major warnings and contraindications it gives are mostly about using these IMP drugs alongside other classes of drugs like NSAIDs or in patients with pre-existing conditions like infections or kidney disease. Not so much negative interactions between, say, prednisone and azathioprine when used as directed, apart from their combined potential side effects like immune suppression. They seem to be used together for synergy.
got it. So the interactions to worry about are more external factors or conditions. Okay, let's pull this together. What does the source tell us about the bigger picture, follow-up, monitoring, the long-term outlook, the prognosis?
Well, it definitely emphasizes that managing IMP is often frustrating. It requires frequent check-ins, reevaluations, and really close patient monitoring.
It's not a set-it-and-forget-it treatment plan.
Not at all. And if the patient starts going downhill, if their signs worsen, the source says that's a clear signal you need to rethink things, change the drug, change the dose, or maybe even reconsider those limited surgical options as a salvage plan like we discussed way back.
Which brings up a really key point. Why is it so important, according to this text, to put in all this effort to get remission, even if it's tough and needs intense management? Why not just manage the symptoms?
The source is very clear on the why. It stresses that you have to try and induce remission because letting the disease just sort of smolder, letting that inflammation bubble away unchecked,
Yeah.
that significantly increases the risk of secondary degenerative joint disease down the road. Chronic inflammation physically damages the joint structures, leading to osteoarthritis on top of everything else.
So getting remission is about preventing that permanent, irreversible damage later on.
Exactly. It's not just about feeling better now, it's about protecting the joints for the long haul.
Makes perfect sense. So what is the expected course? What's the overall prognosis, according to this source?
It paints a mixed picture, honestly. It notes that recurrence, the signs coming back after remission, is seen with moderate frequency. It's fairly common.
Okay, so remission isn't always permanent.
Often not. It also highlights that the erosive forms of IMP are likely to keep progressing. For those, a cure isn't really expected. Remission is the best case goal.
Right.
Similarly, forms linked to lupus, SLE, and that feline chronic progressive form, FCPP, they also tend to progress commonly and carry a more guarded prognosis.
Guarded meaning less optimistic.
Yeah, less certain, more likely to have ongoing issues. However, the source does offer a bit more optimism for other non-erosive forms of immune polyarthritis. It says they generally have a good prognosis.
So that difference in prognosis, depending on the specific type of IMP, is a really major takeaway from this source.
Absolutely. It underscores how variable this disease category can be. You can't just lump it all together.
Yeah. Wow. This deep dive into the source material really gives a detailed roadmap for tackling immune-mediated polyarthritis, doesn't it?
It certainly does.
It shows it's complicated.
Yeah.
Balancing different drugs, constant monitoring for remission and side effects.
And managing expectations. Knowing that for some types, cure isn't likely and recurrence is definitely possible.
But the consistent message from the source seems to be, you have to manage it aggressively. Aim for remission, maintain it if you can.
That's the core message, because preventing that ongoing joint damage is just so crucial for the patient's long-term well-being and function.
So here's a final thought to leave you with, drawing from what this source tells us. Considering that recurrence happens moderately often, and for some really tough forms like the erosive ones or FCPP, a cure isn't really expected and the outlook is guarded. What is this intense focus on achieving remission, knowing might not last, tell us about the sheer ongoing commitment and the fundamental challenge involved in managing chronic immune-mediated diseases in general? Something to think about.